Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 154 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, MHA, a 37-year-old female patient presents to her primary care provider, PCP, for evaluation of an abscess in her groin region. She reports a subjective fever at home. Some of her pertinent vitals include a body temperature of 38.2 degrees Celsius, a heart rate of 82 beats per minute, a blood pressure of 118 systolic and 78 diastolic, and a respiratory rate of 20 breaths per minute. Her PCP examines the abscess, performs an incision and drainage I&D, and sends a sample for culture and susceptibility testing. She has a past medical history significant for polycystic ovarian syndrome. She has no known drug and food allergies. So my question to you is, which of the medications listed below would be the most appropriate empiric choice in MHA's case? Would it be A. doxycycline for 10 days, or B. cotrimoxazole for 14 days, or C. cephalexin for 10 days? Or would it be D. no empiric antimicrobial therapy is indicated at this time? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. doxycycline for 10 days. This patient needs antimicrobial therapy because she is febrile, and the infection is in an area that is difficult to completely drain with I&D, making answer D incorrect. Because of the prevalence of MRSA, it should be covered for empirically, making answer C incorrect. Either trimethoprim, sulfamethoxazole or doxycycline would be appropriate, but the recommended therapy duration for outpatients is 5 to 10 days, making answer B incorrect. The best answer would be doxycycline for 10 days, making answer A correct. Please advance to the next question. The PCP decides to initiate cotrimoxazole and follow up with the culture result to adjust the antimicrobial, if necessary. The culture and sensitivity results that return on day 3 after the I&D are as shown in the table. Briefly pause the video and scrutinize the table. The Staphylococcus aureus groin is resistant to oxacillin but susceptible to clindamycin, doxycycline, cotrimoxazole, and to vancomycin. So my question to you is, which of the medications listed below would be the best therapy for MHA at this time? Would it be A. continue cotrimoxazole for 10 more days, or B. switch to doxycycline for 10 more days, or C. continue cotrimoxazole for 7 more days, or would it be D. change to oral linezolid for 7 more days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Continue cotrimoxazole for 7 more days. This patient has MRSA caused by the oxacillin resistance on the culture and susceptibility. Linezolid would be efficacious for treatment, but it is expensive and should be reserved for more serious infections or for infections that do not respond to first-line therapy. That makes answer D incorrect. Changing to doxycycline would still be efficacious, but this is unnecessary because the patient already takes trimethoprim, sulfamethoxazole, which makes answer B incorrect. In addition, 10 additional days of therapy would be too long because the patient has already received 3 days of an effective antimicrobial. That makes answer A incorrect. Therefore, the best answer would be to continue trimethoprim, sulfamethoxazole for 7 days to complete 10 days of therapy, which makes answer C correct. Please advance to the next question. And the next question reads, PKJ, a 57-year-old female patient presents to your accident and emergency department for evaluation of her face, which appears bright red and edematous. She noticed the redness starting about 3 days ago but thought it might go away. On examination, the accident and emergency medicine physician notes that the redness covers most of the anterior of her face and that it is raised, with a well-defined margin. Some of her pertinent vitals include, a body temperature of 37 degrees Celsius, a heart rate of 76 beats per minute, a blood pressure of 126 systolic and 78 diastolic, and a respiratory rate of 21 breaths per minute. She has no known drug or food allergies. So my question to you is, which of the pathogens listed below is the most likely cause of PKJ's infection? Is it A. Enterococcus faecalis, or B. Streptococcus agalactiae, or C. Streptococcus pyogenes, or is it D. Staphylococcus aureus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Streptococcus pyogenes. Given the patient's clinical presentation, particularly the raised border and well-defined margins, she almost certainly has erysipelas. The most common cause is Streptococcus pyogenes. That makes answer C correct. Staphylococcus aureus and Streptococcus agalactiae are possible but rare causes. That makes answers D and B incorrect, and Enterococcus is not associated with erysipelas, which makes answer A incorrect. Please advance to the next slide. And the next question reads, which of the regimens listed below would be the most appropriate treatment for PKJ at this time? Would it be A. Admit to the hospital to initiate piperacillin, tazobactam and vancomycin, or B. Admit to the hospital to initiate cefazolin, or C. Discharge home with cotrimoxazole, or would it be D. Discharge home with cephalexin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Discharge home with cephalexin. This patient has no signs and symptoms of systemic infection, hence, this infection would be considered mild and treated on an outpatient basis, making answers B and A incorrect. Because MRSA is such an uncommon cause of erysipelas, there would be no need to empirically cover for it unless there were specific risk factors. Thus, cephalexin would be the best answer, making answer D correct and answer C incorrect. Please proceed to the next question. And the next question reads, KEM, a 23-year-old male patient has been admitted to the hospital for the treatment of necrotizing fasciitis. 7 days ago, he went to the beach with colleagues, where he sustained several deep cuts to his legs after jumping into shallow water. 48 hours later, his legs quickly became bright red, with bullous formation, which began spreading quickly to his thighs. He was rushed to your accident and emergency department, where he underwent immediate debridement of the wounds. The surgeon initiated empiric antimicrobial therapy with vancomycin and meropenem. KEM has since been to the operating room twice for further debridement. The surgeon plans further surgical procedures. During the first surgery, culture and susceptibility was sent of the excised tissue, which today shows growth of Aeromonas hydrophilia. So my question to you is, which of the medications listed below would be the best pharmacotherapy for KEM at this time? Would it be A. change to penicillin plus clindamycin, or B. change to doxycycline plus ceftriaxone, or C. discontinue antimicrobial therapy because of surgical excision, or would it be D. continue meropenem and vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. change to doxycycline plus ceftriaxone. The recommended treatment for necrotizing fasciitis caused by Aeromonas would be doxycycline plus either ciprofloxacin or ceftriaxone. That makes answer B correct. Antimicrobials should not be discontinued at this time, especially because the patient is likely to have to return to surgery, making answer C incorrect. Because the pathogenic organism is now known, continuing empiric broad-spectrum antimicrobials would not be recommended, making answer D incorrect. Penicillin plus clindamycin is the treatment of choice for Streptococcus pyogenes, but because the patient is not infected with this organism, this regimen would be inappropriate, which makes answer A incorrect. Please proceed to the next question. And the next question reads, PAM is a 76-year-old male patient who presents to his primary care provider for evaluation of a large ulcer on his right foot. He has a long-standing history of uncontrolled type 2 diabetes, as well as hypertension, congestive heart failure, and chronic renal insufficiency. On physical examination of the foot, the PCP notes that it is edematous, erythematous, warm to the touch, and tender, and that it emits a foul odor. The erythema is measured at 2.5 centimeters. Some of his pertinent vitals include a body temperature of 38.5 degrees Celsius, a heart rate of 95 beats per minute, a blood pressure of 105 systolic and 58 diastolic, and a respiratory rate of 24 breaths per minute. CMP and CBC results include a WBC of 15 × 10⁻³ cells per millimeter cubed, neutrophils account for 90%, a serum creatinine of 2.6 mg per deciliter, a BUN of 30 mg per deciliter. He has no known drug or food allergies. So my question to you is, which of the options listed below would be the most appropriate treatment for PAM now? Would it be A. admit to the hospital and initiate piperacillin, tazobactam plus daptomycin, or B. admit to the hospital and initiate vancomycin plus ceftazidime, or C. prescribe levofloxacin plus clindamycin for 21 days, then return to the clinic for re-evaluation, or would it be D. prescribe cotrimoxazole for 14 days, then return to the clinic for re-evaluation? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Admit to the hospital and initiate piperacillin, tazobactam plus daptomycin. This patient has PEDIS4 and severe infection according to IDSA criteria. He also has SIRS, given his vital signs and laboratory values. Because his infection is severe, he should be admitted to the hospital for initial treatment, making answers D and C incorrect. Ceftazidime and vancomycin would be appropriate for empiric antimicrobial coverage, but because this patient has chronic renal insufficiency and his serum creatinine concentration is 2.6 mg per deciliter, vancomycin would probably not be best, making answer B incorrect. Daptomycin and piperacillin, tazobactam provide broad coverage against gram-positive and gram-negative organisms and against obligate anaerobes and would probably not cause major toxicities in this patient. That makes answer A correct. Please advance to the next question. And the next question reads, SHC, a 65-year-old female patient is currently in the hospital for the treatment of a prosthetic joint infection, abbreviated as PJI. 3 weeks ago, she underwent elective knee replacement surgery. However, 7 days after the surgery, she began having acute pain in the affected knee, and yellowish drainage began from the surgical incision. She was given a diagnosis of a PJI, and the surgeon decided to perform debridement in an attempt to save the prosthesis, which has so far been successful. The culture and susceptibility results from the synovial fluid show the following: Staphylococcus aureus susceptible to oxacillin, clindamycin, doxycycline, cotrimoxazole, vancomycin, linezolid and to levofloxacin. SHC has been receiving antimicrobial therapy with cefazolin plus rifampin while in the hospital. However, she is doing so well clinically that the surgeon would like to send her home on oral antimicrobials if possible, and asks for your recommendation. So my question to you is, which of the regimens listed below would be the best therapy for SHC? Would it be A. ciprofloxacin for 6 months, or B. dicloxacillin for 6 months, or C. cephalexin plus rifampin for 6 months, or would it be D. levofloxacin plus rifampin for 6 months? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. levofloxacin plus rifampin for 6 months. For PJIs with confirmed Staphylococcus aureus, rifampin-based therapy is always recommended because of its propensity for penetration of biofilms, making answers B and A incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 155.